Thank you. So we'll get to the dirtier side of trauma, I guess. These are the complications from the skeletons of our depth of our closets here. And I see some of my fellows back there, so they may recognize some of these complications. And I've learned a lot from these trauma patients because there's challenges in every aspect and as they flow through your hospital system. And the one thing that I learned really early is that these patients, as you accept them to your hospital, the risk starts right there. I work at a level 1 trauma center, so when the surrounding hospitals call you and you accept the patient, the responsibility of taking care of that patient begins at that moment. So I'll give you some examples of some of the problems that could occur, because a lot of times you don't really know these patients. You get wrong information or very vague information about these patients, and you're thrusted upon the responsibility to take care of these patients. So the first example is an elderly woman who fell from standing. And at an outside institution, she was billed to have a normal neurological exam. But, and we accepted the patient was being transferred, but unfortunately there was some delay in transfer to the hospital. And when she was in the vehicle to come over to our hospital, she became quadriplegic. And you can see that in the MRI that she received at our hospital, that she has a cord injury. So we took her to surgery for fixation and laminectomy. But unfortunately, she remained AJA, and she passed away from the complications from that. The second example, which is a very common theme at Pittsburgh, unfortunately, is an elderly person with an ankylosing spondylitis who falls and has neck pain. The patient is billed as neurologically intact initially, so it gets transferred, and we tell them to get an MRI because we need that for the pre-op planning. In the MRI machine, the person actually becomes quadriplegic. So slowly, first complains of some sensory deficits, and then by the time the MRI is completed, that person is AJA. So you can see on the MRI machine that the person actually had more extension moment on the alignment and has a cord injury at that level. So again, we took the patient urgently to the OR, did the surgery, but again, patient expired from the complications. So the third example of this is a 21-year-old person who was involved in a motor vehicle accident versus the motorcycle versus a bus, was intubated, sent to the ICU directly. And we were planning to do the surgery urgently that day, but unfortunately, because of the pulmonary complications, we couldn't take the patient. It was seen that the patient was bucking multiple times in the bed. And they performed multiple bronchs and pulmonary procedures on the patient. And 24 hours later, again, patient has cord injury. And you can see on the MRI that he's got a cord injury at a very unstable odontoid fracture level. So in all the three cases, the spine surgeons were named in a litigation. And the basis for their complaint was that there was not enough supervision for the team that was involved. So again, even before you touch the patient, you're at a risk for these situations. So the lesson that I learned very early on is that communicating your plan to the team is key. And you have to document those communications to sort of mitigate yourself away from these risks. And it goes down to all the way to the ICU team, to the EMT, and also even the radiology techs that you're supervising. When it comes to the documentation and the communication, I find that communicating the goals of care with the family is extremely difficult in this population because many of these patients are getting sicker, and you're expecting complications from them. Some of them will not make it out of the hospital, but because of the urgency of the situation, you can't get hold of the family and can't talk to them about how bad the situation is. So there's an example of this. This is an 89-year-old male who fell from the stairs, was found unresponsive, has multiple comorbidities that you can see. And the CT and the MRI shows that he's got a severe cord injury. It's a bad situation overall. He's got a severe pre-existing spinal stenosis and a bad unstable injury that you know that this is a complete spinal cord injury and this patient most likely will not survive this injury. But we couldn't find the family. I couldn't talk to them. And because of this, he was taken to the OR for the definitive procedure. And after the fact, we were able to sort of talk to the family and tell them about the graveness of the situation. They were clearly angry about it, and they were upset that the patient was in this situation. But and I wanted to know why, why is the patient not moving? Is this part of the surgery? Is part of the problem? And you try to kind of catch up in the background, and it's almost impossible to do. Well, after the first day, we ended up getting a CT scan of the C-spine, and it turns out that one of the screw on the left side was going through the dominant vert, and subsequent CT scan of the head showed that he had a stroke. So now you're in a situation where the family is upset with the poor communication. There's no documentation of the goals of care, and you know that this patient is not going to survive this injury. So, and this patient ended up passing away about 3 days later. So we do have this problem of not being able to communicate the exact gravity of the situation with the family on a very frequent basis. So at our hospital, we have this process called Surgical Pause Program that we initiated. And this is a program where if we know that the patient is not going to survive or do very poorly, we get a group together rapidly within 24 hours and try to have a quality goals of care documentation with the family so that we can talk to them, give them the risk and the benefits of the surgery, and let them know that this is a bad situation. And the process gets meticulously documented. And we found that this pause program, it was a pilot program, but it did increase the quality of documentation and the discussions without delaying the necessary surgery and the mortality that's associated with the injury pattern. So as we move on to sort of the surgical part, I think the difficulties of surgical positioning was also discussed in other ICL lectures previously. But I find that when you're trying to do surgeries on these big, large patients with multiple extremity fractures, the positioning is probably the most overlooked but difficult part of planning. So one of the cases, just for illustration, is a 54-year-old male who's morbidly obese, was in a motorcycle accident, has this extension distraction injury. And because he was so morbidly obese, I put him in a Mayfield tongue. And when we were doing the surgery, he slid down on the bed and created this extension moment. And you can see on the left-hand side there that intraop X-ray shows that he has extended through that fracture line. So unfortunately, again, he loses SSCPs during the surgery, and post-op angiogram shows that he has a dominant vert occlusion. And he passes away after about a week later also. So again, you see a lot of my patients don't do very well with these complications. They don't go back to NFL or they don't go back to play. The lessons in these is just that I just tend to think a lot more meticulously through the positioning for these patients. In this case, I learned to pad the knees, make sure you flex the bed so the patient doesn't slide too much during the case. So you don't put them in this oblique position so that the patient doesn't slide off and create this extension moment. Post-surgically, again, I think most of us realize that surgical site infections are probably the most common complication that we deal with, especially these patients with AJA injuries or spinal cord injuries. They require tracheostomies, and the saliva is dripping directly into the anterior wound or the posterior wound. So what we started to do in our institution is to use the incisional vac quite judiciously. And I leave them on for 2 to 3 weeks until patient's wound is completely healed or sutures are ready to come out. Or if the patient is ambulatory until they're mobilized, and we take them off. And in our short series, we've shown that this is much more superior to just a traditional dressing in terms of preventing infections. There's dangers in non-op care too, and probably the one thing that I will point out in my experience is that elderly and frail patients have very poor reserve for immobilization of their cervical spine, cervical collars. We take care of a lot of odontoid fractures and C1 fractures at our institution, and we're very judicious about not putting them in anything that's going to immobilize them too long or too rigid. So this is a case, 82-year-old, and this is not the only example that we have of this. With non-displaced type 3 odontoid fracture with osteopenic bone that's non-displaced, was put in the Miami J collar, and on day 2, I had aspiration pneumonia, was intubated, and then didn't make it out of the hospital. So again, I've learned very early on that the elderly have very low reserve for cervical immobilization. I use soft collars on these patients on a regular basis, and if I end up doing surgery on these patients, typically I wouldn't put them in any collars at all. So I would say that the trauma patients, in conclusion, are just very difficult patients to deal with. And when you're taking care of these patients, you kind of get what you get. You don't have a chance to sort through them on an elective basis and pick the healthiest patients. The most important thing that I would emphasize again is to document your communications and talk to your other team members to make sure that they're clear on what the goals are and what the injury pattern is. And no matter what you do, I find that something will happen, and bad things will happen. And unfortunately, that's the nature of trauma. And if it does, I try to remember that I'm not alone, and there's other people who are going through the same thing. Thank you.